Okay, my name's Chantel Manhart. I'm going to talk about renal and urologic systems. This is chapter 29 for pathophysiology. So chapter 29, structure and function of the renal and urologic systems. So we're going to start with structures of the kidney. The kidneys are a pair of organs located in the posterior region of the abdominal cavity behind the peritoneum. They lie on either side of the vertebral column with their upper and lower poles extending behind the 12th thoracic vertebra to the 3rd lumbar vertebra. They have a tightly adhering capsule, the renal capsule, that surrounds each kidney, which is embedded in a mass of peritoneal fat. The capsule and the fat layer are covered with a double layer of renal fascia composed of fibrous tissue. The hilum is a medial indentation in the kidney and is the location of the entry and exit of the renal blood vessels, nerves, lymphatic vessels, and the ureters. So when you're looking at the kidneys filter blood. They remove water, soluble waste. They help control the blood pressure and composition. They help maintain red blood cell levels. The kidney is composed of greater than 1 million teeny closed packed nephrons, and functional units of each kidney consists of the glomerulus, the proximal convoluted tubule, the hoop of Henle, and the distal convoluted tubule, and the collecting duct. So when we talk about the glomerulus, it's a tuft of capillaries that loop into the Bowman's capsule. It lies and it fingers pulsed into the, if you think about like a bread dough, and it together with the juxtaglomerular cells and the maculodense cells form the what we call the juxtaglomerular apparatus. The control of the renal blood flow and the glomerular filtration and the renin secretions occurs at this site. The proximal convoluted tubule joins the loops of the Henle, which extends into the medulla. The cells of the thick segments are actively transported through several cellules, but are not composed of thin squamous cells with no active transport function. The distal tubules has straight and convoluted segments, and it extends from the macula densa to the collecting ducts. A large tubule that descends down the cortex and through the renal pyramids of the inner and outer medullae, draining urine into the minor calyx. Sorry, I know it's hard to follow. So look at the picture so it kind of makes more sense. So when we're talking about the glomerulus, it is it's made up of different layers, and it consists of like I was saying before, it consists of compact tufts of capillaries that encase the thin double-walled capsule, okay, which we call it Bowman's capsule. Then it has these capillaries that consist of 4 to 8 vessels and are arranged in like a fish-like structure, and they arise from the afferent arterioles, and they empty into the efferent arteriole, which carries blood into the peritubular capillaries. Then the glomerular capillaries membrane is composed of 3 layers. It has the capillary endothelial layer, the basement membrane, and the single-celled capillary epithelial layer. The epithelial layers line the glomerulus and interfaces with blood as it moves through the capillary. This layer contains many small perforations called fenestrations. The epithelial layer then covers the glomerulus, is continuous with the epithelium that lines Bowman's capsules. The cells of the epithelial layer have unusual octopus-like structures that possess a large number of extensions or foot processes which are embedded in the basement membrane. These foot processes have like little slit pores through which the glomerular filtrates pass. The basement membrane consists of a homogeneous acellular meshwork of collagen fibers, glycoproteins, and mucopolysaccharides. Since the membrane layer determines the permeability of the glomerular capillary membrane due to its not porous like the endothelial layer and epithelial layers. So when we're talking about the nephron, it is made up of the glomerulus, Bowman's capsule, proximal convoluted tubule, the loop of Renal, the distal convoluted tubule. There are approximately 1.2 million nephrons. The nephron's function is it filters plasma at the glomerulus. It reabsorbs and secretes different substances along the tubular structures. It forms a filtrate, a protein-free fluid, which we call an ultrafiltration. It regulates the filtrate to maintain body fluid volume, electrolyte composition, and the pH within narrow limits. Glomerular filtration is a movement of fluid and solutes across the glomerular capillary membrane into Bowman's space, free of red blood cells and plasma proteins. The tubular secretion reabsorbs 75% of the water, salts, glucose, and amino acids. The glomerular tubular balance is adjustments of reabsorption of sodium and water, the loop of Renal and distal tubule, the elimination or excretion of the final substance, which is urine. So when we're talking about renal blood flow, the kidney receives 1,000 to 1,200 mLs of blood per minute. The glomerular filtration rate measure is the best measurement of renal function and the first step in urine formation. The glomerular filtration rate is approximately 125 ml per minute. It filters the blood plasma. The tubular reabsorption, when we're talking about that, its filtrates are moved into the tubular segments of the nephrons. It reabsorbs salt, glucose, and amino acids. The secretion is is ammonia, urea, and uric acid, and it's 1 ml of 125 mLs per minute is excreted in the urine and 60 mLs per hour. So when we're talking about urinary structures, we're talking the bladder is a bag of smooth muscles, fibers that forms the detrusor muscles and its smooth lining of the uroepithelium. As the bladder fills with urine, it distends and the layers of the uroepithelium within the lining of the slides past each other and becomes thinner as the bladder volume increases. And so when that happens, that's forming those detrusor muscles, okay? And then the trigon is a smoother triangular area between the opening, of the two ureters and the urethra. Now, when we're talking about the ureters are 30 centimeters long. They're long, they intertwine smooth muscle bundles. They pass obliquely through the posterior aspect of the bladder, and they have this peristaltic activity that is downward motion. And so what happens is it's gonna, and there's a micturition compresses the lower end of the ureter to avoid urine reflux, because we don't want urine going back up the ureter. We want it going down the ureter. And then at the urethra, we have this internal and external sphincters. The ureter is 3 to 4 centimeters in females and 10 to 20 centimeters in men. Now, the other thing we have to think about is the urethra extends from the inferior side of the bladder to the outside of the body. A ring of smooth muscle forms the internal urethra sphincter at the junction of the urethra and the bladder. So the external urethral sphincter is composed of a striated skeletal muscle and is under voluntary control. So, like we were talking about the different sizes of the urethra, the male urethra is actually broken into 3 segments. It's broken into the prostatic, the membranous, and the penile. Hormones and the renal function. So the sympathetic nerves release catecholamines. This stimulates afferent renal arterial vasoconstriction and decreases the RBF and the GFR. Sorry about that. And increases renal tubular sodium and water reabsorption and increases blood pressure. Decreased afferent renal sympathetic nerve activity produces the opposing effect, and the increased response regulates water and sodium balance. Renalase is a hormone released by the kidney and heart that promotes the metabolism of the catecholamines, and in this way participates in blood pressure regulation. So when we're talking about the neural regulation, we have the sympathetic fiber that regulates size, afferent and efferent arterioles. And there is no significant parasympathetic regulation, like we just talked about. So when we're talking about the hormones, we have an increase, when we're talking antidiuretic hormone, there's an increase in antidiuretic hormone causes the collecting ducts and the distal convoluted tubules to become permeable to water. Water moves in and out of the ducts and into the blood. So when we have a decrease in antidiuretic hormone, the collecting ducts become impermeable to water, and water is not reabsorbed from the filtrate and is excreted. So when we're talking about aldosterone, the aldosterone level, if increased, the tubules increase reabsorption of sodium from the filtrate and decreases reabsorption of potassium, water, and sodium, thus moves from filtrate into the blood and excretes potassium, and excess potassium is excreted. So if we have a decrease in aldosterone levels, the tubular absorption of sodium potassium is normal. Water is not reabsorbed from the filtrate and it is excreted. So when we're talking about the atrial natriuretic peptides and the B-type natriuretic peptide, the atrial is made in the overstretched atria, and the B-type natriuretic peptide is made by overworked ventricles. Both cause vasodilation and sodium and water excretion and decrease blood pressure. So then we get this urodilatan, and it is a renal natriuretic peptide produced by cells in the distal tubule and collecting duct. It increases renal flow, causing diuresis. So when we're talking about the renin-angiotensin-aldosterone mechanisms, it plays a role in blood pressure regulation. Renin is an enzyme formed and stored in the cells of the arterioles by the juxtaglomerular apparatus and released by the decreased blood pressure and loss of fluid. So then what happens, we have increased water reabsorption by the kidneys and increasing water permeability of the distal tubules and collecting ductus. The drop in blood pressure also is detected by each nephron's juxtaglomerular apparatus, which responds by secreting renin. Renin will convert circulating plasma protein called angiotensin to angiotensin 1. Angiotensin 1 leaves the kidney and enters the circulation. It enters the lungs and reaches angiotensin converting enzyme, which catalyzes it to the conversion to angiotensin 2, which stimulates the release of aldosterone, release of aldosterone from the adrenal cortex, which will slowly boost water reabsorption by the kidney by increasing reabsorption of sodium. Because angiotensin 2 also stimulates the secretion of ADH, it serves as an additional link between the ADH and aldosterone mechanisms. So vitamin D is necessary for the absorption of calcium and phosphate. Vitamin D needs to go through the liver and the kidneys to be metabolically active. And then when you're talking about erythropoietin, is released when decreased oxygen to the kidney. It stimulates RBC production, and it's stimulated by the tissue hypoxia secondary to anemia, poor oxygenation, cardiac, and pulmonary etiologies. Chronic kidney disease leads to the anemia because decreased ability of the kidney to form erythropoietin. Tests of renal function, renal clearance, and renal blood flow. The renal clearance techniques determine how much of substance can be cleared from the blood by the kidneys per given unit of time. Application of this principle permits an indirect measure of GFR, tubular secretion, tubular reabsorption, and RBF. So when we're talking about this, give me 1 second here. Sorry, guys. I need to get a drink of water. As we were talking about this, GFR is best estimate of function of the renal tissue and is important for assessing and monitoring kidney damage and drug dosing. So our creatinine clearance is a natural substance that is produced by the muscle and released into the blood at a relatively constant rate. It is commonly used as an estimate clinically. Creatinine clearance provides a good clinical measure of the GFR because only on the blood sample is required to, in addition to an accurately collected 24-hour volume of urine, and it can really give us a good idea of our GFR. Blood plasma creatinine gives us a chronic decline in GFR over weeks or months and is reflective in the plasma creatinine concentrate. And if you're looking at that level, it's usually going to be a 0.7 to 1.2 mgs per deciliter. When we're looking at BUN in the blood, it reflects the glomerular filtration and urine concentration capacity. And it's going to range from 10 to 20 mgs per deciliter. Urinalysis is a non-invasive and relatively inexpensive diagnostic procedure. I consider it just a test. It's fresh, clean, voided specimen. Color. It's going to be based on color, the protein, the pH, the specific gravities, and sediment, and it's also, what we're going to do is we're going to look and see is there RBCs, WBCs, leukocytes, and different things in it. Also, we're going to run a urine culture, which usually comes back at 24 to 72 hours. So when we're talking about urodynamic tests, sorry about that. You're hearing my dog goofing off there. Which I do urodynamic testing, and it's really a very good test because we won't do any surgery on a bladder without doing this test, for one, because it tells us a lot of information. So cystometry is a measurement of the bladder pressure. It's determined using a pressure measurement catheter. Fluid volume and pressures are measured as the bladder is filled with fluid. Simultaneously, pressures may be measured in the rectum. Sensations of bladder fullness are also recorded because what we do during coughing or straining and can lead to involuntary bladder contractions. So what I'm going to do is I'm going to have a patient go through, and they're going to, as I'm putting sterile water in their bladder, they're going to be telling me when they get their first sensation their bladder's filling. They're also going to, I'm going to stop it every 100 cc's, and I'm going to have them cough and do a Valsalva maneuver. And I'm also looking to see, are they going to leak during this when they're doing those things. Also, we ask, when do they get a strong urge to urinate? And also during this, everything's being recorded on what their bladder itself is doing. And when are they getting contractions? Bladder capacity is 350 to 750 mLs for men. For women, it's 350 to 550 mLs. Residual should be under 30. The detrusor pressure is usually 10 cm per H2O. The uroflow fluorometry measures time it takes to empty a full bladder of urine and flow rates. It may be faster with urge incontinence or slower with prostatic obstruction. And so what happens is a patient will come in, they will sit down, and it will measure their urine flow going into a beaker and the amount. Then what happens is they're placed on a table, and a post-void residual, which measures the residual urine in the bladder after voiding urine can be removed with a catheter, is done, and that should be under 30. Sometimes if we're in the hospital and remove a catheter and they can't urinate, we'll use ultrasound imaging to see how much urine's left. Electromyography measures the nerve impulses and muscle activity in the urethral sphincter by placing sensors on the skin near the urethra and the rectum, or by placing sensors on a catheter placed in the urethra or the rectum. So when we're doing this test, there are sensors on the catheter. We also put a sensor up on women into the vagina. Men, that sensor goes up the rectum. On the women, there are sensors placed next to the rectum, and then one up into the vagina. In video urodynamics, imaging of X-rays or ultrasound waves during fluid filling or bladder shows size and shape of the urinary tract. So when we're talking about aging and the renal function, 45% of people older than 70 years of age have chronic kidney disease. Hypertension and diabetes accelerates the decline of renal function. So we start to see decrease in renal blood flow and GFR. We're going to see alterations of sodium and water balance. the number of nephrons and the decrease due to renal, vascular, and perfusion changes. We're going to see responses to acid-base changes delayed. We're going to see an increased risk for drug toxicity, and we're going to see alterations in thirst and water intake. Sorry guys, I do apologize. I had a little bit of a distraction in the background. Now we're on to Chapter 30, alterations in renal and urinary tract function. Urinary tract obstruction. So now we're talking about urinary tract obstruction is an interference with the flow of urine at any site along the urinary tract. The obstruction can be caused by an anatomic or a functional defect. So it could be obstructive uropathy. It could be any anatomical changes by any obstruction. So, and the severity is based on its location, completeness, involvement of the ureters or the kidneys, the duration, and the cause. Okay, so upper urinary tract obstruction. We're talking hydroureter, accumulation of urine in the ureter, hydronephrosis, enlargement of the renal pelvis and calculus, ureter hydronephrosis, dilatation of both the ureter and the pelvic calculus system. Sorry, I've got to get somebody happy here for a second. Who needs a treat? I take it because I'm distracting him. The tubulointerstitial fibrosis happens if the obstruction is not relieved and the dilatation leads to an enlargement and the fibrosis with the disposition of excessive amounts of collagen and other proteins. Compensatory hypertrophy and hyperfunction is how the body partially counteracts the negative consequences of the unilateral obstruction, resulting of the two growth processes of obligatory growth occurs under the influence of somatic somatomedines, and compensatory growth occurs under the influence of still unidentified hormones. The causes of the unobstructed kidneys to the increase in size of the individual glomeruli and tubules, but not the total number of functioning nephrons. Post-obstructive diuresis is a physiological response and is typically mild, representing a restoration of fluid and electrolyte imbalance caused by the obstructive uropathy. Risk factors for this include bilateral obstruction, impairment of one or both kidneys, ability to concentrate urine or reabsorb sodium, acquired nephrotic so one of the things is acquired acquired nephrogenic diabetes insipidus, hypertension, edema, weight gain, congestive heart failure, and uremic encephalopathy. So kidney stones. The prevalence of stones in the United States is approximately 7% in women and 10% in men, and it has increased in the past 20 years. That does not surprise me. I don't know about you. I think a lot of the reason it's increased is what we eat. The reoccurrence rate is approximately 30 to within 5 years, which means we don't learn from what's causing them. Kidney stones or calculi or urinary stones are masses of crystals, protein, or other substances that form within and may obstruct the urinary tract. Our risk factors can be gender and age, race, geographic location, seasonal factors, fluid intake, diet, and occupation. Kidney stones are classified according to the minerals that make up the stones. So there's kidney stone formation. So there's a couple different, what do you want to call it, theories again for this. But the main one is this supersaturation of one or more salts. The presence of a salt in a higher concentration than the volume able to dissolve that salt. The precipitation of the salt from liquid to solid state. And the temperature and pH. They grow into a stone via crystallization or aggregation. The other theories, sorry guys, the other theories that they think maybe play a factor with this are maybe the crystal growth inhibiting substance. All right, try that again. Crystal growth inhibiting substances. Sorry, I'm being attacked by a little pupper, so I'm trying to get him preoccupied again. Reduction isn't such that the substances that prevent stone formation, such as potassium citrate. Also, there's this particle retention. It's primarily at the papillary collecting ducts from urinary stasis and anatomic abnormalities or inflammation. The other is matrix organic material as they act as a nidus for stone formation. Let me get through this slide and I'm putting them away. There's stones. The stones can be from calcium oxalate or calcium phosphate. There is struvite stones, which is magnesium ammonium phosphate. There's uric acid stones. Those are usually people that have high nitrate diets. And there's cystine stones, sorry guys, which is caused by amino acid metabolism, which is a defect in that metabolism. So they can't metabolize amino acids, so they get these cystine stones. Give me a minute and I'll be right back. Okay, sorry about that, guys. I got rid of the puppy. Okay, so kidney stones, manifestations, renal calculi is described as a moderate or severe pain. I'm sorry, I said renal calculi, renal colic. I apologize. Renal colic is described as a moderate to severe pain, often originating in the flank and radiating to the groin. Usually indicates obstruction of the renal pelvis or proximal ureter. Colic that radiates to the lateral flank or lower abdomen typically indicates obstruction in the mid-ureter, and bothersome lower urinary symptoms indicate obstruction of the lower ureter or ureterovesicular junction. The pain can be severe and incapacitating and may be accompanied by nausea and vomiting. It is usually evaluated by the history and symptoms and focused exam. Um, we will usually do a stone and urine analysis. Stone, if we catch it, we have them strained till we catch it. Imaging stays include an intravenous pyelogram, IVP, or a kidney, ureter, bladder X-ray, KUB, a spiral abdominal CT. Our treatment is usually high fluid intake, decreased dietary intake of stone-forming substances, and stone removal. So goals of treatment is to manage pain, promote stone passage, reduce the concentration of new stones formation. We want to make their urine more alkaline, so we're going to change their diet to do that. We're going to remove stones with either percutaneous lithotomy, ureteroscopy, or ultrasonic or laser lithotripsy to fragment the stones for excretion in the urine. Prevention is to increase fluids to generate 2.5 liters of urine per day, to avoid colas, soft drinks with phosphoric acid, to avoid dietary oxalates, which is chocolate, beets, nuts, rhubarb, spinach, strawberries, tea, wheat, and bran. We usually tend to do less animal protein, limit sodium intake, and calcium. Lower urinary tract obstruction. So this is disorders of the lower urinary tract are primarily related to storage of urine in the bladder, emptying of urine through the bladder outlet. Neurogenic bladder is a term for bladder dysfunction caused by a neurogenic disorders. Lesions developing in upper motor neurons of the brain and spinal cord result in dyssynergia, I think I'm saying that wrong, sorry. Loss of coordinated neuromuscular contraction and overactive hyperflexive bladder function. Neurologic disorders that develop above the point of maturation center, resulting in detrusor hyperflexion or overactivity. This is an upper motor neuron disorder in which the bladder empties automatically when it becomes full and the external sphincter functions normally. This is an example of stroke, traumatic brain injury, dementia. Brain tumors are an example of this disorder that would result in this. Lesions involving the sacral micturition center below S1 may also be termed Cauda equine syndrome, or peripheral nerve lesions resulting in detrusor arthexia, a lower motor neuron disorder. The result is a contractile detrusor or atonic bladder with retention of urine or distension. Stress or overflow incontinence usually go along with this. Overactive bladder syndrome is a syndrome of detrusor overactive characterized by urgency with involuntary detrusor contractions during the bladder filling phase that may be spontaneous or provoked. Overactive bladder is defined by the International Continence Society by syndrome of urgency without urge incontinence and usually associated with frequency and nocturia. Anatomic causes of resilience to urine flow include urethral stricture, prostatic enlargement in men, pelvic organ prolapse, and tumor compression. Urethral stricture is a narrowing of its lumen and occurs when infection, injury, or surgical manipulation produces a scar that reduces the caliber of urethra, more common in men. Proximal urethral strictures causes more severe obstruction that do strictures of the distal urethra. Prostate enlargement is caused by an acute inflammation, benign prostatic hyperplasia, or prostate cancer. Pelvic organ prolapse in women causes bladder outlet obstruction when a cyst is still, which is the downward protrusion or the herniation of a bladder into the vagina, descends below the level of the urethral outlet. A cystocele reaches or protrudes beyond the vaginal introitus, creates the greatest risk of obstruction, particularly if the bladder neck has been surgically repaired without simultaneously repairing the cystocele. So what happens is with that, you're going to see a bulging coming out the vagina. And what can happen is not only can bladder fall in there, but you can have small intestine or colon going also into there. And you also get like a rectocele, which includes that. So it can be a big surgery to fix. Partial obstruction of the bladder outlet or the urethra initially causes an increase in the force of the detrusor contraction. If the blockage persists, afferent nerves within the bladder wall are adversely affected, leading to urinary urgency and, in some cases, overactive detrusor contractions. Ultimately, the bladder wall loses its ability to stretch and accommodate urine, a condition called low bladder wall compliance, and the detrusor loses its ability to contract efficiently. Low bladder wall compliance chronically elevates intravesicular pressure, greatly increasing the likelihood of hydronephrosis, and impaired renal function. Renal tumors are estimated at 61,560 of new cancer cases and 14,080 deaths in 2015. Renal adenomas, benign tumors, are uncommon but are increasing in number. The tumors are encapsulated and are usually located near the cortex of the kidney. They can become malignant, so are usually removed. Renal adenocarcinomas are the most common. Renal neoplasma, 85%, represent about 2% of cancer deaths. Represent 2% of cancer deaths. Renal transitional cell carcinoma is rare and primarily arises in the renal parenchyma and the renal pelvis. Renal cell carcinoma usually occurs in men between 50 and 60 years of age. Cigarette smoking, obesity, and uncontrolled hypertension are risk factors. Surgical resection. 5-year survival rate is about 90% for stage 1. Cystitis is most common in women due to shortened urethra and closeness of the urethra to the anus. A UTI is inflammation of the urinary tract, epithelium caused by bacteria. Acute cystitis can be a painful bladder syndrome, interstitial cystitis, acute chronic pyelonephritis, and most common pathogen is E. coli. So when we're talking about a urinary tract infection or acute cystitis, the most common site of a UTI, cystitis is an inflammation of the bladder. Its manifestations is frequency, dysuria, urgency, lower abdominal and or suprapubic pain, low back pain. Treatment is based on the culture and sensitivity. We will do a dip for leukocytes, estrase, nitrate, reductase can be used for a diagnosis of uncomplicated UTI. We will usually treat with antimicrobial therapy or antibiotics for 3 to 5 days for uncomplicated. Complicated UTI will be 7 to 14 days. We're going to have them increase their fluid intake and avoidance of bladder irritants, and we may use urinary analgesics such as pyridium or Urabel. We are going to have them repeat urine cultures. Should be obtained 1 week after treatment, monthly intervals for 3 months if it's a reoccurrence. Painful bladder syndrome or interstitial cystitis is a condition that includes non-bacterial cystitis. It can be viral. It can be non-infectious cystitis from radiation, chemical, autoimmune hypersensitivity. Interstitial cystitis can occur for most commonly in women ages 20 to 30 years who have symptoms of cystitis such as frequency, urgency, dysuria, nocturia, but with negative urine cultures and no other known etiology. It's non-bacterial infectious cystitis is most common among those who have immunocompromised. Non-infectious cystitis is also associated with radiation or chemotherapy treatments for pelvic or urogenital cancers. This cause of interstitial cystitis is unknown. It's autoimmune. It's thought to be an autoimmune reaction. It may be responsible for inflammatory responses, which include mast cell activation, altered uroepithelial permeability, and increased sensory nerve sensitivity. The pain lasts longer than 9 months. They do get this bladder fullness, frequency, small urine volume, and chronic pelvic pain. The treatment, there's no single treatment effectiveness. Overall, we tried this intravesicular therapy, sacral nerve stimulation, and Botox treatment to relieve symptoms. Surgery is used in refractory cases. Pyelonephritis is a bacteria gained access into the kidney from the lower urinary tract or bloodstream. Acute pyelonephritis is an infection of the ureter and renal pelvis and interstitium. It can be due to urinary obstruction. Reflux of urine from the bladder are the most common underlying risk factors for this. It can also be caused from E. coli, Proteus, Pseudomonas. Its clinical manifestations are fever, chills, flank pain, groin pain, dysuria, and costovertebral tenderness. It's diagnosed from a UA and urine cultures, clinical signs and symptoms. If it's complicated, it needs to have blood cultures and urinary tract imaging. Microorganisms are treated by specific antibiotics. They need urine cultures 1 week and 4 weeks after treatment. Chronic pyelonephritis is persistent or recurrent episodes of acute pyelonephritis that lead to scarring of one or both kidneys. The recurrent infections can be an obstructive process, clinical manifestations, may be hypertension, frequent dysuria, and flank pain. Urinalysis, intravenous pyelography, and ultrasound are used diagnostically. Treatment is related to underlying cause. Glomerular disorders. So glomerular nephritis is inflammation of the glomeruli or glomerulus. There's usually glomerular damage. Any damage to the glomerulus can decrease the efficiency of filtration. Damage to the glomerulus will allow blood cells, lipids, or proteins to pass into the urine. It can be immunologic abnormalities are the most common, drugs or toxins, vascular disorders. Systemic disease is usually secondary or viral causes. It could be hereditary also. So when we're talking about glomerular nephritis, immunologic depositions of circulating antigens, antibodies, complexes into the glomerulus, reactions of antibodies in situ against planted antigens within the glomerulus, non-immune glomerular injuries related to ischemia, metabolic disorders, toxins, exposures to drugs, vascular disorders, vasculitis, and infections. So it could be due to all three of those reasons. They can have manifestations. They usually have major symptoms if severe: hematuria with red blood cells cast, proteinuria that exceeding 3 to 5 grams per day with albumin as a major protein. They may have oliguria, hypertension, edema, nephrotic sediment, nephritic sediment. Diagnosis of glomerular disease is confirmed by the progressive development of clinical manifestations and laboratory findings of abnormal urinalysis with proteinuria, red blood cell casts, white blood cells. Treatments are related to treating the primary disease, preventing or minimizing immunoresponse, and correcting accompanying problems such as edema, hypertension, hyperalbuminemia, hyperlipidemia. Antibiotic therapy for underlying infections that may be contributing to ongoing antigen-antibody responses. Corticosteroids decrease antibody synthesis and suppress inflammatory responses. Cytotoxic antigens may be used to suppress the immune response in cortico-resistant cases. Nephritic syndrome. So, primary cause of nephritic syndrome include minimal change nephrotic and focal segmental glomululosclerosis. Nephritic syndrome is diagnosed when the protein level in a 24-hour urine collection is greater than 2.5 grams. And the serum albumin level decreases and concentrations of serum cholesterol, phospholipids, and triglycerides increase. Nephrotic syndrome is commonly treated by consuming a moderate protein restriction of 0.8 grams per kilogram body weight per day, low-fat, salt-restricted diet, and by prescribing diuretics. We'll also find that they're hypoalbuminemia, edemia, hyperlipidemia, and lipouria, and vitamin D deficient. Acute kidney injury is a sudden decline in kidney function with a decrease in glomerular filtration and urinary output with accumulation of nitrous waste products in the blood, as demonstrated by elevation in plasma creatinine and blood urine nitrogen levels. Renal insufficiency refers to a decline in the renal function to about 25% of normal, or a GFR of 25 to 30 mLs per minute. Serum creatinine and URA are mildly elevated. Renal failure refers to a significant loss of renal function. When less than 10% of renal function remains, that is termed end-stage kidney disease. Acute kidney injury. When the kidney fails, or what we should say is termed kidney renal failure, refers to a sudden loss of renal function. It's usually due to a condition that produces acute or chronic shutdown in renal function. And this is when the kidney fails and less waste is removed and more waste remains in the blood. Nitrogenous compounds build up in the blood, increase in BUN, increase in creatinine. Renal function approximated by increased creatinine levels. And it's usually a concurrent situation. It is generally reversible, and acute renal failure has a mortality rate of 10 to 60% depending on the underlying etiology. It has different stages. Pre-renal is most common cause of acute renal failure. It's caused by impaired renal blood flow. The GFR declines because of the decrease in filtration pressure. It's usually due to hypovolemia, hypotension, and hypoperfusion. Such as with a mass PE. Intrarenal is an acute tubular necrosis, is the most common cause of intrarenal failure. It can be post-ischemic or nephrotoxic. It causes oliguria. It's usually due to glomulopathies, malignant hypertension, coagulation defects, bilateral acute pyelonephritis. We have post-renal, which occurs with renal tract obstructions that occur usually in the kidneys bilaterally, so it's obstructive uropathies, edema, tumors, or neurogenic bladder. Okay, so the initial phase of ARF is asymptomatic. As renal function is lost, however, symptoms appear. Clinical manifestations vary depending on the ARF phase. In the initial phase, this kidney injury is evolving. Prevention of injury is possible. Then we start into the oliguric phase, decrease urine output, electrolyte disturbances, we have fluid volume excess, oxemia, metabolic acidosis. We're establishing kidney injury and dysfunction, and this is urine output's its lowest during this phase, and we're going to see serum creatinine and blood urea nitrogen both increase. Then we go into the recovery phase. Symptoms begin to recover, and this is where we're going to start diagnostic procedures for ARF include those to identify both the renal injury and its underlying cause. These procedures consist of history, physical exam, BUN, creatinine, blood chemistry, arterial blood gases, urinalysis, CBC, renal ultrasound, biopsy. And also during this phase, we're going to see diuresis common, decline in serum creatinine and urea, increase in creatinine clearance, and then treatment is based on the phase we're on. The diet is high in calories, carbohydrate, but restricted in protein, and sodium, potassium, and phosphates, and hypertension management, anemia treatment with synthetic erythropoietin, and infection prevention strategies. So chronic kidney disease is, there's two factors that have consistently been recognized in abundance for renal disease, and that's proteinuria and angiotensin II activity. Progressive loss of renal function that affects nearly all organ systems with chronic kidney disease. It's associated with hypertension, diabetes, intrinsic kidney disease. It comes in stages. You've got your normal with a GFR of greater than 90, mild it's 60 to 89, moderate is 30 to 59, severe is 15 to 29, and stages less than 15. You've got your chronic renal disease. We have proteinuria contributes to tubulointerstitial injury by accumulating in the interstitial space of the nephron tubules and activates complementary proteins and other mediators and cells such as macrophages that promote inflammation and progressive fibrosis. Angiotensin II promotes glomerular hypertension and hyperfiltration caused by afferent arteriolar vasoconstriction, and also promotes systemic hypertension. Creatinine is constantly released from muscle and excreted primarily by the glomerular filtration. In chronic kidney disease, as glomerular filtration rate declines, the plasma creatinine level increases by a reciprocal amount to maintain a constant rate of excretion. As GFR continues to decline, plasma creatinine concentration increases. The clearance of urea flows a similar pattern, but urea is both filtered and reabsorbed, and its level varies with the stage of hydration. So, with chronic kidney disease, fluid and electrolyte balance, we have sodium and water balance. Sodium is excretion increases with sorry, I had a distraction there. Sodium excretion increases with obligatory water excretion, leading to sodium deficit and water volume loss. Concentration and dilution ability diminishes. Potassium balance, tubular secretion increases early. Once oliguria sets in, potassium is retained. Acid-base balance, We have metabolic acidosis when the GFR is 30 to 40%. We have calcium, phosphorus, phosphate, and bone issues. We have a reduction in renal phosphate excretion, decreased renal synthesis of 1.25. We also have vitamin D3 and hypocalcemia. So then we start seeing fractures. We'll also have protein, carbohydrate, and fat metabolism issues. We'll have anemia. They'll have lethargy, dizziness, and low hematocrit are common. So, signs and symptoms of kidney failure can be epistaxis, anemia, sallow pigmentation, pruritic excretions, bruising, anemia, impotence, infertility, muscle weakness, peripheral neuropathy, edema, bone pain, nail changes, pleurisy, hypertension, anorexia, nausea, vomiting, red eyes, lethargy, seizures, and coma.